What's that sound? Okay. We'll let the last one in. Okay, welcome everybody. Thank you so much for joining us this afternoon for our webinar on supporting the older child and transition and the relationship between anxiety and asthma. My name is Sarah Nelson. I'm the Deputy Director of Transformation and Health Inclusion here at Healthy London Partnership, and I am also a cardiothoracic nurse by background. I have been leading this asthma work in London since its inception, and so I am delighted to be joining you to chairing this webinar today in what is our 4th year of our Ask About Asthma campaign, so it's very close to my heart. I am just going to pop up some slides. I can find them. And I just want to remind people of a little bit of etiquette before we start properly with the sessions. If you could just mute yourselves and have your cameras off while you're talking. And if you want to use the group chat during the actual 2 speaker sessions, and towards the end, I will allow you people to come on to their cameras as they raise their hand and perhaps ask some questions of the speakers. So I'm delighted today to welcome Sam Prigmore from St George's Hospital, who is a consultant nurse, respiratory nurse there. She has an impressive CV, having been specialised in cardiorespiratory nursing since qualifying, and was one of the first respiratory nurse specialists to be appointed in the UK. She has been instrumental in developing respiratory nursing teams in both the acute and community setting, and she has extensive experience in nursing patients with asthma, in particular severe and difficult asthma and transitional services. She has worked closely with CCGs to develop and redesign respiratory services, representing nursing in the development of the National Clinical Strategy for COPD and asthma. And she is also a respiratory clinical lead for South West London Integrated Care System and a member of the London Respiratory Network Clinical Leadership Group. She has been actively involved with British Thoracic Society, Primary Care Respiratory Society, and the Association of Respiratory Nurse Specialists, as well as being a trustee for the British Lung Foundation. She has held honorary lecture roles with Imperial College and Royal Brompton Hospital and is a trainer for Education for Health. And as if that isn't enough, she is currently studying for a PhD in nursing. I'd also like to welcome Fran Beresford, who is Principal Clinical Psychologist at the Royal Brompton Hospital, and she's going to talk to us today about asthma and anxiety in children and young people. She trained as a clinical psychologist at UCL and worked in child community services and inpatient mental health services before specialising in paediatrics. She has a special interest in difficult asthma for nearly 15 years and has been privileged to work closely with the multidisciplinary difficult asthma team at the Brompton. She has been involved with research in asthma, focusing on adherence and psychosocial issues, and she teaches and supervises. She uses a variety of therapeutic approaches in her practice and established and chairs a national respiratory interest group for psychologists. Before I move on to their sessions, though, I just wanted to mention how important transition is. As a mother of a child with a long-term condition who's gone through transition and safely gone to university a few years ago, I recognise only too well how important it is to get this right first time and the benefits of starting it early. My daughter had diabetes diagnosed at the age of 5, and we recognised very quickly that this was something she was going to have to cope with for life. And this is very similar to those children that have asthma. This year, we have obviously had to struggle with the additional aspects of COVID, pandemic and the greater concerns about our children's education, the risks of infection and supporting their mental health during this period. I hope that this session is going to help provide you with some tips and to help you support parents and young people, whether you're a health professional or a young person or a parent watching this at this moment. So without further ado, I want to hand you over to Sam. Just
let's try unmuting myself. Can you see my slides? Just check. Okay, let me try again. I've got problems with my slides.
No, I can see a set of slides.
Okay.
Oh, not now.
Okay.
Try sharing again.
Okay, let me just, right, I think they were stuck. Right, okay, thank you. So thank you for inviting me along to talk today around adolescence to asthma transition. And you'll see here, I'm an adult nurse.
Sam, sorry, the slides aren't up at the moment.
Aren't they?
No, they did pop up and then they went again.
Oh, okay. Are they there now?
I think they're coming. Yes.
Yeah,
you're there. Go ahead.
Okay, I have a problem that they let me. Yes, they are. Let me move. Okay, can you still see them?
Yeah, all fine.
Yeah, perfect. Okay, so so as I said, I'm obviously I'm an adult trained nurse, but I am a mother of 2 children. So similarly, have been through children and the adolescent period that they go through. And whilst my son, who was my second born, was an absolute dream, my daughter was a nightmare. So I can understand completely for how difficult it can be when children with healthcare needs are transitioning across and taking independence. But I survived it, and I think that's the bit that's important in here, that we all go through challenges when our children are growing up anyway. And I can only, from my own experience for patients that I've seen who transitioned across, is some of the challenges are not just for the child, it's also for the parent. And I think that bit is actually quite an important aspect to remember, especially when the parents have been doing a very good job in looking after those children with their long-term conditions. So it's surviving being a parent is actually very important. So why is it important in asthma in particular? And I think the thing that I would say with this in particular is that we know we've got big problems. So within the UK, asthma mortality rate in the young population is high. It's highest, second highest amongst the 15 to 19-year-olds. That transitional period, which is important. And we know that when you look at the data and looking about it historically, where in other countries there's been an improvement in mortality rate, within the UK it's actually either the same or getting worse, and which is actually quite concerning, that we should be trying to make some inroads into why mortality is so high within this population. And I'm sure you're all very familiar with the review of asthma deaths that we know there within the children. And the numbers were relatively small, but they were large enough to be of a big enough concern. And any death is a concern, especially within children with asthma. But we recognised there that people were, there was inadequate care. So we were missing some of the basic care with these patients. And there was poor recognition of the outcomes that were important to survival, really. And unfortunately, despite NRAD being published several years ago now, so the best part of 6 years ago, over 6 now, we haven't had any impact on that. So there were several recommendations that were made at the end of NRAD, which unfortunately only one of the recommendations has actually come through in those 6 years, and that is around the asthma audit. And so it's concerning that we haven't really turned a tide on this and we're not changing practice. So why is transition important? We've got very clear guidance, and actually I was asked to present at a local talk in St George's last year on transition, and I looked into transition in a bit more detail, and I hadn't appreciated the guidance that was out there that's stipulated by NICE. So we should be providing transitional services for patients, and it's actually important just to look at some of those issues. So what's the start point, what's the end point, and when do you start to transition across? So our practice is we start to transition across from around 15 years old up to 18, 19, 20, depending on that child's need. And I think this is very apparent in the guidance here, is around it being developmentally appropriate. So you have to pick the right time to transition across. And there isn't that rigid threshold of what age, but if you don't start to plan it, it becomes slightly problematic. And I've been working with one of our paediatricians, Anne Christopher, for the last, it's about 14 years on transition. It might be slightly longer, but we sort of set it up because we recognised there was a bit of a gap and a bit of a need, and who was going to pick those children up when they came across and how we could manage it. So we have we have a transitional clinic every 2 months where we both attend. We both actually jointly run the clinic and manage the patients that are in that clinic. So it's a joint appointment. Parents are obviously invited along as well. We don't, with our practice, we're not seeing them separately, but we can do. So we'll allow parents to attend, and we'll also allow the child to attend by themselves as well. So the whole purpose with the NICE recommendations is to provide that support before transfer. So we have had a few cases where patients, they've just pitched up in my adult clinic and I've never met them before. And that's quite a challenge, partly for me, because I haven't met them, but also for the child coming across, because they're coming to a very, very different environment when they've been in a paediatric outpatient area to coming over to an adult side, it can be very scary. And the clinic that I runs alongside clinics with people with lung cancer that are very unwell, people on oxygen, etc. So it can be a little bit of a shock to the system. So the idea is that we really try and support best practice as recommended by NICE, which is around the same individual seeing those people as well and following them through. And there are quality standards for transition as well, which are including that transition pathway. It's ensuring that we meet these children on a regular basis, but they have a named worker. So actually, until they transition across, they still sit within with the paediatric department. But in that transitional period, we will start to develop a bit more of a joint approach. So, for example, I will offer my email address to a lot of the patients that we're seeing, so they can contact us directly. And we introduce them very carefully into that adult side. And so I'm very careful about what time their appointments are, to try and make it as flexible and comfortable for them as possible. And following up any missed appointments is very important, because they do fall through the net, and they slip through the net, which is slightly concerning. So the guidance is there. We've got quality standards that we should be trying to meet as well. And actually, the other thing that's really been, for me, really important is when you look at what's happening locally within London, and within the documents that have been developed to drive up the standards of asthma care across London. There's an area within the policies and guidance which is suggesting we have this structured, formalised transitional process from child to adulthood to ensure that they do not fall through the gaps. Now, this is within, from my point of view, I'm coming from secondary care, and if they're in just being managed purely by primary care, that transition is probably pretty seamless, that they are automatically followed through, will be seen by the same practice nurse, hopefully, that has been doing their annual reviews anyway. But within secondary care, it is slightly more tricky to make sure we get it right, and to make sure that we address some of those needs that they have as going forward. Gosh, that's a loud car. So I just wanted to highlight this, and this is really looking at those patients within secondary care and the impact of severe asthma that has on patients. So this paper was published a couple of years ago, and I work with patients with severe asthma as well as transitional patients as well. But what's really struck me here is, despite maximum treatment, if we look at those adolescent patients and the impact it has on their quality of life, and having severe persistent asthma that's being mismanaged or poorly managed, and they have residual symptoms, it has a huge impact on their quality of life and also on their self-esteem, which is so important for the young people growing up. They need to believe and have their own self-esteem and be strong. And I think it's one of those areas that's really impactful, that really notices that we can get the right treatment for them and get them to understand their disease, that their quality of life will hopefully improve. What's also interesting in this same paper as it looks at patients' perception of good control of asthma. So it's based on, the first one looks at whether the adolescent patients feel that their asthma is well controlled. And you can see here, only 4% feel that their asthma is poorly controlled and uncontrolled, with the majority of them feeling that it's well controlled or partially controlled. But when you then compare their symptoms and against the asthma control score for questionnaire that's used in GINA, it's a complete reverse. So you can see here that only 4 of them had well-controlled asthma, and the majority of them had uncontrolled or partially controlled asthma. So perception of symptoms is really important. In fairness, it's not a lot different to adults as well, but I think it just highlights that adolescent patients may not recognise their symptoms, and certainly in my experience, many of them will have symptoms that they're not aware of, and they do not recognise the severity of their symptoms when they're happening. So let's just think of a few patients. So these are fictitious patients, and I will tell stories as I go along with some of them, just to sort of highlight some of the patients we've actually seen. But we've got David, who's atopic. He's 16 years old, lots of admissions to hospital. He's never been intubated. We have Grace, who was born prematurely. She has multiple food allergies. She's had episodes of anaphylaxis as well in the past, and she also has atopic asthma. Micha, who is 17 and a half and atopic, numerous admissions, has been intubated twice in the last year. So typical patients that I've seen in our transitional clinic, and I'm just going to flag up as we go through the case studies as some of the issues that are probably the most apparent that come up as we go through. And it won't surprise you that this is all about preparing them to leave home and fly the nest. So they need to have an understanding of their asthma, what triggers it, what to do in an exacerbation, how to self-manage, when and where to get help, and actually navigating the health service as a young adult is actually quite challenging, and helping them and arming them with the right information is really important. So there are things that you need to consider. So thinking about risky behaviours that all teenagers go through, so smoking, drugs and alcohol, and just being aware of the impact it can actually have on them. So, you know, I'm amazed that we have patients that have severe asthma in our transitional clinic that smoke, that will actually admit that they smoke. They will admit to smoking illicit drugs as well, because it's under peer pressure. So it's no different to probably any other adolescent, apart from the impact it has on their health and their symptoms is really problematic. And similarly, alcohol can cause problems with inhibitions, etc. So they may take risks, and that's especially important to consider with children that have ATP, maybe food allergy, where they may be exposed to things that could trigger an anaphylactic reaction. And I think it's one of the things that really differentiates my caseload is the patients that come over from the transitional clinic. A lot of them will have coexisting food allergies that actually cause a lot of problems. So educating about the importance of anaphylaxis management is really necessary. And they need to take some responsibility as well. And so for many patients, their parents have taken the role of organising their medication, ensuring they've not run out of inhalers, and arranging follow-up appointments, etc. And the management plans that we tend to provide, certainly in childhood going through to adolescent, are very different to the ones that we would probably offer to them in the adult world. So thinking about how do we need to adapt a management plan to fit that patient's needs is quite important going through transition. So it's around understanding their asthma, understanding good control and why it's important. If they have underlying allergies, understanding the importance of controlling their asthma to prevent further severity of a reaction should they be accidentally exposed to something that they're allergic to. And often they'll have coexisting eczema as well. And I'm no specialist in dermatology, but I've had to go on quite a steep learning curve to try and get a good understanding of the basic management of eczema, because actually that's one of the things that tends to be more troublesome, particularly with young women, if they have got significant eczema and it's affecting their body image, and it bothers them a lot. So understanding what's driving their symptoms is really problematic. And they have to understand it's a long-term condition. So as Sarah mentioned, her daughter had a long-term condition from the age of 5. They are unlikely, if they're getting to transition, to grow out of asthma. So they're likely to have asthma long term, and they're likely to have food allergies long term as well if we haven't challenged them by the time they have got to 18 and we know that they still have a reaction. They're likely to have these long term conditions that need to manage. And stresses of life get in the way. So the pressures of exams, they really, and this year in particular has been really troublesome for them. So some of them have been delighted not to have taken exams, and other feels that they have been shortchanged and that they haven't been able to demonstrate their full abilities. But I've had some lovely emails from some of our transitional patients telling me that they've got their A-level results and where they're off to, and they're looking forward to seeing me when they started university. So I think there's some really positives there, but the stress of actually making those life decisions about going to university, leaving home, are really problematic. And family dynamics, as I said, my daughter, when she was 13, was an absolute nightmare. She's lovely now, but she was really challenging as a 13-year-old, and up to about 15, until she really identified herself as a person. It felt like constant loggerheads over challenging boundaries, and these are no different to any other adolescent. But when you're actually affecting their potential, their health has been affected because of the stress it causes, is problematic. And I'm sure Fran will cover more of these aspects as she goes through her presentation. Peer pressure is a real problem, especially where we're talking about risky behaviours, etc. And relationships. So where you've got young adults in relationships and they've become very involved very quickly. I think one of my worst scenarios when we had young lady came in for her clinic appointment, and she admitted that she was in a long-term relationship, and then her mother said, "Tell her the rest." And she said, "Oh, and I'm pregnant." And then she said, "Tell her the rest." And she was pregnant with twins, and her mother had thrown her out of the house as well. So, it can be really challenging for these poor young people as they're growing up and facing life going forward. So David, let's just think about him. So all of the bits that we've just discussed are relevant to all of the cases I'm going to provide. So actually taking consideration and making sure that they understand these issues is really important. So David's had lots of admissions, and actually what we know is that his admissions were really down to the fact he was poorly adherent with treatment. And so the range is massive, the best will in the world, and in studies we can improve adherence, but on the whole, adherence in asthma across the board is pretty poor. And I think it's really difficult to actually understand why and how we can actually address that. But I think it is around perception of symptoms. So for many people, they feel it's okay if they have asthma that they need to use their reliever inhaler, whereas as healthcare professionals, what we want is for them to have be symptom free, and that's across adults as well as transitional people. But they do have problems, and we know in adolescents and children it's particularly challenging. So addressing adherence is paramount, and trying to understand why and what they're doing. And things that we find that have been really quite helpful is just to review what medication they're currently on. So they may well be on medication, the same medication or the same device that they've been on for many, many years, and actually changing their device, asking what they like and what they don't like about a device. And I'm sure this happens anyway, but whether it's coming from an adult side, and I'm quite good at saying, well, now you're in the adult world, we can start to look at maybe slightly different devices and think about things slightly differently. And it may be thinking about, actually, let's give them something that's once a day, because with adherence would actually be better, and we can actually address their symptoms better as well. Thinking about and actually reviewing it. So I'm very good at saying to patients, just to be honest with us, because actually it just helps us understand why your asthma is not as well controlled as we'd like it to be. Have you forgotten to take your inhaler? Let's try and think of ways of how you can remember to take it, rather than the parents having to remind them. And that can cause some real issues with parents nagging children, and the children kicking off because they're being nagged by their parents to take their medication. And of course, what we want them to do is to do it independently and to remember. So it may be thinking about, well, hang on a minute, what do you do every day without fail? And this chap in particular used to go on his skateboard everywhere. So he had a little note on his skateboard to remember to take his inhalers, because that skateboard went everywhere with him. So thinking about practical things is really important. I mentioned briefly about outpatients and the importance of just pre-warning them what to expect when they come over to the adult side, because it can be quite scary. It can have some really positive effects. I can think of one chap in particular who came in and he said, I'm definitely going to stop smoking now because I don't want to end up like that man out there on oxygen. So actually seeing somebody actually unwell with it, some much older than they are, actually seem to have some kind of benefit in those scenarios. But equally, you can have problems if they're being admitted to hospital. So if they come onto an adult ward, it's really helpful for them to have a familiar name and face that they can actually contact, and the ward can contact myself or my team to say, can you come and see this person? They've been admitted. So they may well have been admitted onto one of our acute medical wards and have brought the average age down by about 60 years. And that can be quite frightening. If you can imagine a young 16, 17-year-old being admitted onto a general medical ward surrounded by confused, muddled people, it can be quite a frightening time, both for child and parent, just around their own safety, etc. So we try, and where we can, is actually try and ensure that they are managed in a most appropriate setting. But it is very difficult as they get into sort of later years. So our children tend to go, under 18 tend to go to paediatrics, and over 18 would be admitted to the adult service. And thinking about the best way of communicating, so by email, by phone, by whatever means, is actually just important that they know how best to contact them. And I'm pretty good that when I've seen people, I'll actually email them. I'll get their email address and I'll email them and say, please respond to my email so I know you've got my email, and then email if you've got any problems. And I think actually that gives them a little bit of independence as well. And I would encourage them to take some ownership over their follow-up appointments, to ensure that we're managing things. The other thing that's slightly problematic in this, when we're navigating our way through the management of their asthma, is actually accessing medication when they're acutely unwell, for example. So how do they actually access an appointment to be seen in primary care when the receptionist will say we've got no appointment? So we have to empower them to be able to have the right tools to tackle those sorts of scenarios, to say, actually, I have bad asthma and I do need an appointment, because most receptionists will give an appointment for an asthmatic, and I think you can actually work quite closely with them, but they need to know how to do that. And we've all been there before ourselves, where it's hard to get an appointment. So I basically will give, and this is across all patients I see, but in particular for the adolescents, the WhatsApp for Asthma UK and their helpline is really useful, so they can get advice for directly from somebody other than myself, or from their practice nurse, etc. So they can get some advice if they need it. So it's quite important to think about different ways of getting it. Talking about COVID messaging is really important at the moment. So, of course, for those that are being transitioned across, we're on our third clinic next week that we're doing as a joint clinic via telephone, and it's really challenging because you don't get a real feel of what's happening with that individual child, and especially if we've not met them before. But it is important just to get you really reinforce the basic messages that we should all be sharing out anyway, around social distancing, ensuring that they've got face covering, reminding them about washing their hands, and isolating if they have any symptoms. The importance of their annual review, so just to make sure that they are being seen if they are due for a review. And I really homed in on regular preventative treatment, that they need to remember that it's so important that should they get COVID, if they've been taking their preventative treatment on a regular basis, that it should hopefully reduce the impact of disease, the impact of COVID, should they be unfortunate to catch it as well. And obviously flu vaccination, and we're coming up to that time, which is really important.
So you've got about 5 minutes.
Yep, that's fine. So let's just think a little bit about Grace. So she was born prematurely, and that brings itself with difficult situations as well. Atopic asthma, lots of food allergies and anaphylaxis in the past. So with the premature adolescents, what we don't know is what's going to happen to their lungs later in life, and I think that's a bit that's quite the challenge for me. So I will have patients that will come through that were being born at 26 weeks, and actually their asthma is really well controlled, but I don't really want to discharge them because I want to know what happens to their lung function going forward. So their asthma can be well controlled, and we're keeping them in clinic and keeping an eye on them, because we just don't know going forward what's going to happen. So and the other bit with Grace and premature babies is often the parental detachment is more of a struggle, because they actually they've had maybe a bumpy time in the beginning of their life, and actually might have had in and out of hospital for a long time as well. What's interesting is with our paediatrician that I work with has looked after many of these children since they were born as well, so it's quite a challenge. Anaphylaxis and actually ensuring that they're on the right dose, they have the right dose of adrenaline, is really important. We do have a slight problem at the moment because we can't access 500 mics of adrenaline, but the guidelines for anaphylaxis is they should be having 500 mics or to inject pens, and we have got a shortage of those, so it is a slight problem. So I will also direct them to Take the Kit campaign from anaphylaxis campaign, which is really helpful to make them realise that actually anaphylaxis will kill people. And it's a bit scary, but I make sure that they see the video. I get up on the phone for them, tell them they need to show their friends it, they need to know how to use it, take their adrenaline autopens with them, take antihistamines with them. So they get a bit of a grilling with me when it comes to anaphylaxis, because it really concerns me. And just finally, Micha. So Micha is 17 and a half years old, atopic. She's a troublesome teenager by any means. She's had numerous admissions, and it's all down to poor adherence to treatment. But also with her, it also relates to poor perception of symptoms. And the way I got round her was I got her to listen to her own chest when she was tight, and she could hear herself wheezing, and it's really turned her management round, and she's in regular contact with me by email for management advice, which is really important. So tips for parents: acknowledge it could be really hard to let go, provide support for them as well. I've had one parent that's cried when I've told her that she's got to let them go, and she just cried and cried. She said, I just can't let my baby go, I can't. I said, you're going to have to. They're going to have to go at some point. Let them independence, let the teenagers speak up, get the story from them. And sometimes you have to be quite hard and firm and say to the parents, I need to hear it from your child, not from you. Helping and supporting them within exacerbation management as well. And the other bit for parents is just to remember that if their child wants them to get a prescription, they will need their prescription, their permission after the age of 18, etc. So as they become recognised as 18 and young adults, that we need permission from the child as well. And then just finally, Asthma UK have a site on their website for transition, which is for parents and for children as well. But I think it's a really good site to direct people to for added advice as well. Thank you very much.
Thank you, Sam. That was excellent. And I love the idea about getting a child to listen to their own chest. That's a really good tip. As Sam has mentioned, that long-term conditions have a really big impact on a young person's life. And this obviously also causes a lot of anxiety, both for the parents and for the child themselves. And so Fran is now going to talk to us about anxiety in young people with asthma. I'll leave it to you, Fran.
Thank you very much, Sarah, and hello everyone. Thank you very much for inviting me to speak today and be part of this amazing initiative. I'm hopefully going to link in nicely with what Sam's been discussing, and my talk is focused really on anxiety and the mental health of young people with asthma. Firstly, I think as a start point, we need to think about how many of the young people we see have significant difficulty with managing anxiety. And the stat I have up here is for paediatrics generally. And when we look at the adolescent age group, we're looking actually at about 15 to 17% of adolescents who have a diagnosable mental health disorder. So that's very high. And we know that if there's maternal depression in the family, their children have a much higher risk of having mental health difficulties. So when we think about young people with asthma, we're looking at probably 3 times that level, which is a huge amount of young people who are struggling with mental health problems. And we also know that only about 25% of those who have difficulties will not be able to access the mental health services that they want to for various reasons, but a lot of that is because there aren't the mental health services available. So I think really when we're thinking about identifying anxiety and what we need to know what it is and how we spot it in young people. So it's an innate adaptive response to danger. We all have anxiety. Anxiety is a really important part of our emotional repertoire. So if we didn't have anxiety, we wouldn't be able to protect ourselves and look after ourselves. It motivates us to do things. So it's a useful emotional response. What isn't so useful is when it actually stops us doing some things. And so we're going to be looking out for young people whose anxiety is becoming unhelpful. And I think with kids and young people with asthma, there are lots of comorbidities, and we need to be aware of those. So anxiety in young people is understandable. It is a huge crossover with asthma and anxiety symptoms, and teasing those apart can be really difficult. And we find that in even very experienced clinicians, they find it difficult to tease apart. So I've heard about paramedics and A&E doctors and consultants who have had that challenge of trying to work out how much is asthma and how much is anxiety. So it's no wonder that families and young people find it difficult. And cognitive behavioural therapy is the most researched treatment for anxiety. With this in mind, a lot of the anxiety information that you will access divides anxiety sort of assessment and intervention into 3 components, and that will be physical feelings, behaviour and thoughts. So thinking about the physical sensations of anxiety, I use this picture a lot with young people and their families, and I ask them to look at that, and I explain that that is what people roughly feel when they're anxious. And we think about how many of those things they also feel due to asthma or due to their medication. And then we think about what feelings they experience and they recognise in themselves. And I ask parents often to pick up on this as well, because there is a normalising in this with regards to the fact that we do all feel anxiety. The sort of thoughts, the sort of behaviours that they also present with are listed here, and you'll probably recognise a lot of these, and you might have others that you could add. We then have the thoughts that people are presenting with. So a lot of these will feed into the anxiety. So not only are they a consequence of the anxiety, they then maintain the anxiety. So all these things are really important to be identifying when working with anxiety and trying to improve management and empower young people to look after themselves. As you know, there's been in anxiety, it presents slightly differently at different ages. And I think adolescence is a time where we see a change in how it's presenting. And I think that can sometimes lead to confusion. And so we see young people arriving in clinic where parents say, you know, they're acting out, or they're smoking, or they're doing things that they shouldn't do, which isn't helping their asthma, or they're very angry. And it's really important to sort of step back and be quite objective at this point, because anxiety can present in these ways. Depression is also something that can present in this way as well. And we use a screening tool. We use the PIED or the HADS, which is the Paediatric Index of Emotional Distress, or the Hospital Anxiety and Distress screening, so that we can start picking up on what's going on for the young people and for their parents. And I think what we do is use that just as a screening tool, and certainly not as a diagnostic tool. And you can access those measures very easily. Obviously, at the moment, we've got the increased anxiety due to the COVID-19 pandemic. Notably, the research came out in August that there is a significant increase in anxiety in girls and young women, and there's also a general increase in depression in older adolescents. So this is something that we need to be really aware of. I think we'll all be hearing the sort of concerns that young people are flagging up. So the sort of things that we're hearing is that people are nervous about going back to school. They're very anxious about that, and there has been quite a lot of school refusal. That is from parents as well as young people. That they're also worried about catching COVID and how that will impact on their asthma. They're worried about wearing masks and not feeling that they can breathe properly in masks. They're worried about passing on the infection to other people who might be vulnerable in their family. And they're thinking about coughing a lot and what other people might think. So the sort of things that we can be suggesting that they do, or ways that we can support them, is thinking about education and helping them understand what their real risks are, helping them think about how they manage their news and social media feeds, encouraging them to connect with others. In actual fact, helping others helps them reduce the anxiety. It disconnects them a little bit from their own anxiety. Making sure that they're exercising, because that helps in anxiety management and it also helps their asthma. Encouraging them to focus on the things that they enjoy, and making them aware that the impact of other people's mood on them. So if there's a lot of anxiety in their peer group, they are automatically going to feel more anxious. I've given you a couple of links at the bottom of this slide so that you can follow up, because there are some really good resources out there. And when we're thinking about how we talk to young people so that they will listen, and also listening so that they will talk, this is really important. And I think particularly working in paediatrics, we come through the service where we're talking a lot with parents, we're then including children increasingly. But when we move into adolescence, there needs to be quite a shift in the way we're communicating. Young people will be pulling away from their parents, and they go through a stage of not only finding it hard to listen to their parents, but sometimes actively doing the opposite of what their parents are asking them to do. So I think as healthcare professionals, we're in that great situation of being able to step in there and say things and have discussions that parents might not be able to have, or that's causing friction. One of the big things is giving enough time. And I know that can be really challenging when there are a lot of patients to see and there is time limits on some of the services that we're offering. I think being aware of the wording and how we use questions is really important. In adolescence, they're shifting to a stage of wanting to solve their own problems. So it's using open questions, multiple choice type questions, ranking questions, so that you are promoting young people observing and noticing and highlighting their own issues, and then thinking about what the solutions might be and what they feel would be the solution that would work for them. And so that we're guiding them rather than just telling them what to do. So one example of this might be using a ranking question. So where 0 is the worst feeling that they've ever had with regards to anxiety, so panic, and 10 is no panic at all. And you can rank that either way, and then giving them a situation and asking them to rank it on that 0 to 10 scale. So for instance, going into school, if worst feeling you ever had was 0 and the best feeling that you've had is 10, how are you feeling when you're leaving the house? How are you feeling when you're reaching school? And how are you feeling when you're in school? And it helps them start teasing apart the feelings that they're experiencing. I think it's really important to help them name those feelings and check in with their experience and see whether that is something that they're feeling. With regards to developing these skills in how to frame questions, etc., motivational interviewing is fantastic. And I would really recommend that people look into doing training in motivational interviewing. I have put a link at the end of this slide where there's a BMJ learning course. It's 1 hour, and I think as health professionals we can access that. So do look into it. There are other things on the internet, and there's a more formal learning if you're interested in pursuing it. I would strongly encourage you to do that. So thinking about what the adolescent brain is going through, and Sam was talking about this, there's so much change going on for young people. It is phenomenal. And I think actually stepping back and giving a little bit of thought to that, having an understanding of what's going on, makes adolescent behaviour appear much more understandable for us and for adolescents. It can be a very confusing time for adolescents. So the limbic centre is responsible for reward seeking and is stimulated by social and emotional variables. And the prefrontal cortex, so in this cartoon, which obviously isn't an accurate representation of what's happening in the brain, but this is sort of an indication of what becomes dominant in the brain. There is a tiny little bit at the front of the brain above the eye that says common sense, and that is representing the prefrontal cortex, and that is where rational thinking is developing, and that develops much more slowly, and that doesn't develop fully until about the age of 24. And therefore what we've got is all those sort of pleasure and excitement areas of the brain developing before the rational thinking. So young people by definition are going to be doing things that they feel will be gratifying before they actually think them through, and we need to be aware of that and help guide people and inform them, young people, inform them that that is the process that is happening. There is a fantastic TED talk which I would recommend that you have a look at. I'm sorry I forgot to put the link on here. It is by Sarah Jane Blackmore, or Blakemore, sorry, and it's called The Mysterious Workings of the Adolescent Brain. I think it's really interesting watching. And just to note that risk-taking is and continues to be an important part of learning. So if you take away risk-taking, young people are much slower to develop independence, confidence, and new skills. So this is a natural development that we want to intervene with because we want them to be safe. However, that slows down their development, so we have to keep that in mind. So the impact on normal development of asthma is considerable, and Sam went through some of this, and I think it is really tough on young people, you know, that their parents are more protective. They have that natural fear of an asthma attack. They have side effects from medication. They're unable sometimes to keep up with their peers. They can be around allergens. There's exercise, there's getting tired. There are hospital appointments to fit in amongst educational requirements, etc. And they've got the risk taking. There are greater consequences, and that can be really irritating, upsetting, frustrating for young people. We all know how challenging change can be. So transition is difficult. There's already so much going on, isn't there? Like Sam pointed out, there's GCSEs, there's everything, all the hormones going on, there's the changes, there's possibly arguments at home. I think the main point is, how do we help them feel ready and prepared? And I think that starts with asking them what they feel they need. The change can be difficult, so we need to acknowledge that. There are huge service differences in what stage they start transition processes. A lot of the young people that we see are in several different services. So how it's managed through the GP or the local hospital for eczema or for allergies or for asthma. So they're going through all these different services, and it might be quite confusing about what's happening where. There is also highlighting that adherence really takes a dip. So the literature shows us, and we're aware that adherence takes a dip, and that is as parents withdraw support and young people take on that responsibility. And we need to acknowledge that openly with parents and young people. And then it's a little bit about choice of when that adherence is going to dip. Is it better when they're 14, 15? and parents might have more say, or is it better later on when perhaps that frontal lobe is developing more and they are more able to reason and think about the risks? So that is something that we need to be addressing. Parent anxiety, as Sam said, is huge, and we need to be listening to parents' worries and helping look after them as well. Young people need to be proactive in seeking help, and that means actually teaching them the skills to do that. Like Sam was saying, help guide them through the NHS systems, etc. And then there is that acknowledgement of turning up and whether they are seen as an adult or a child, and it can be confusing, and they do need that preparation. What can we do to help manage anxiety? Well, I think there is the listening and acknowledging the difficulties and giving them the safe space to do that. We need to provide clear information about the anxiety-provoking situations, be aware of our own reactions. This stage can be frustrating, and I have certainly seen that in paediatrics. Healthcare professionals want asthma to be managed to keep the young person safe. Families want that as well. And yet we've still got this risk-taking that is inevitably going to happen. We need some space to look after ourselves so that we can offer that non-judgmental approach. And we need to think about how we can offer that within teams or through peers, our colleagues supporting us. Connecting regularly, either with their peers or with other good role models through adult contacts. That might be through teachers, through sports, through family, friends, uncles and aunts, etc. Create healthy routines, thinking about diet, sleep, exercise, etc. Limiting the exposure to the media, social media, etc. And thinking about how they might do that and what limits they want. And thinking about emotional regulation, so time out, breathing exercises, recognising and naming emotions.
Fran, you've
So
got about 5 minutes.
Okay, what can we do to help manage anxiety? Psychoeducation is my first and forefront. I would say, here's the link that I talked about. Go and have a look at this link. See if you feel comfortable with sharing it with young people. I think it's really important that young people understand what anxiety feels like and therefore can connect what anxiety is and what asthma is. Clear understanding of their asthma and good inhaler techniques, and I'm sure everyone's doing that, but it's really important in reducing anxiety. Asthma plans, really empowering young people to take a responsibility in developing their asthma plans to fit with their needs. Breathing techniques, checking in that they have ideas of what breathing techniques to use. Mindfulness is fantastic. I know young people, quite a lot of young people I speak to are not keen on mindfulness, but there are great results when we look at how effective it is. And then if those sort of things aren't working, then thinking about therapy. CBT is the chosen therapy. However, there are other therapies out there that can be effective. And anxiolytic medication is also a possibility. However, it's not promoted in paediatrics. And if you want to access therapy, where do you access it? So within the hospital, you might be lucky enough to have a paediatric psychology service that you can refer to. Play teams often have great expertise in anxiety management. Clinical nurse specialists might be interested in doing more training and working with young people with anxiety. Child and Adolescent Mental Health Service, or CAMS, or adult services as children get older. And those are more difficult to access. The referral threshold can be quite high. So I've added in here the children and young people's improving access to psychological therapies. Have a look at that website and see how young people might access that. And of course, GPs have counselling services that they have access to, and schools increasingly have good counselling services. And so, sorry, going this way, these are 3 final slides, and I can leave you to look at these at a later time. But breathing techniques, these are two really simple and easy breathing techniques that I would recommend. Mindfulness, Headspace is great, and they do some free sessions. The Be Mindful is a course that is online. It costs £30, but it's through the NHS, or originally was when it was researched, and it has some great results at reducing anxiety symptom reporting. And other super sites that you can go and check out are these organisations or charities. So if you're thinking of putting together a leaflet, go and look at these sites, because there might be things that you can download or print out that you can be using directly from them. And if children and young people are using apps, please do check them out on cyberguide.org. I have that's a correction I want to make. Cyberguide.org is a website that has expert reviewers, and go and look up apps that young people are talking about to make sure that they're legitimate and good ones. And finally, my final slide, these are books for parents and books for young people. The only one that I haven't read that I would ask you to double check before you're recommending it to people is The Parenting the New Teen in the Age of Anxiety. It looks like a really good book. I'm hoping to get it and have a read of it. If you do and you've got views on it, do let me know. I'll be really interesting. The Stuff That Sucks and You Are Awesome are super books for young people. Many thanks.
Thank you, Sam. That's excellent. I particularly recognise the lovely slide on anxiety, flight and fight response. Definitely recognise some of those symptoms before starting to chair this exercise and this session. So I'm going to ask you if you want to take your slides down and come on screen, and invite Sam back to join us as well. And we will have some questions from people. If you want to, oops, I'm raising my own hand. If you want to raise your
slides disappeared.
hand. Sorry?
Have the slides disappeared?
Yes, they've disappeared.
Good.
That's brilliant. Yes, if people want to ask any questions, just raise their hand, and they may want to come on screen at the same time. But in the meantime, I'd really like to ask you myself, as in how COVID has actually changed your practice. Oh.
Are you asking Sam?
Whichever one of you wants to say, because it probably is relevant to both of you. Sam can go first if you like.
Okay, so it's changed my practice hugely, because we're not seeing anybody face to face at the moment, unless they are a physical inpatient, and that has its problems. I think actually engaging and understanding the patient group is really, really hard if you haven't got an existing relationship, and trying to understand the symptom burden that they may be experiencing if you're challenging the diagnosis has become a real problem. And I think it's trying not to lose the momentum that we've grown and actually developed the skills in trying to be really finite in getting the right diagnosis to treat people appropriately. But just simple things in checking somebody's inhaler technique when you're not seeing somebody face to face is really, really hard. It's really difficult.
Yeah.
I think at Brompton we're doing a mixture of face-to-face, certainly like Sam, inpatients, obviously it's still face-to-face. Outpatients, there are some children still coming in to see people directly, and I have done that, but there is the PPE and there's the mask, and that makes things more difficult. And then online, I think I've done a variety of sort of Zoom and Team and FaceTime with young people and with parents, and that has worked actually really well. I find it really difficult with younger children, but with certainly the teens, they're very used to working online and are really comfortable with it. So I have found that I will certainly be carrying on after this, and we're actually just doing a service evaluation and getting feedback from people to find out what they have felt about using online therapy. So hopefully there are things that we will take forward from this that might be helpful, which also being a tertiary service means that people don't have to travel in. So I don't want them to avoid travelling in, because that might be promoting their anxiety or feeding into their anxiety, not facing the challenge, but it does mean that they miss less time off school, etc.
Yeah, I mean, online use has a lot of advantages, but it also has an impact on potentially those people who don't have access to the technology, and we need to be very mindful of not increasing any sort of additional inequity really in our service.
Yes.
Yeah. So to either of you, what's been the most challenging experience that you've had with a young person, and how did you manage that? Have you got any tips for others?
I think my pregnant girlie with twins was probably one of the most challenging, because I just was slightly flabbergasted by the whole scenario, that she was in a hostel at 16 with asthma, with expecting twins by herself, and I really struggled with that personally, because I just really felt for her, but she actually matured and developed into the most fantastic mother of these twins, and was a success. I don't think I did anything apart from was just there to help her and help navigate her, because she was by herself and effectively disowned, and it was actually very sad, but she actually came out of it okay the other side, which is the important thing.
Yeah, very important.
That sounds incredibly tough.
It does,
really.
very.
And what it makes me think of is your own well-being, Sam, because I think we become very emotionally invested, don't we? Yeah. And it's very hard not to sort of step in that parental role, and it's how do you balance looking after their needs and supporting them. So I think I'm really in admiration. That sounds like a very tough case. I think I'm more in the paediatric side, so I think the things that I hear about is when young people are sort of really risk-taking, and parents can see it and the team can see it, and there's this huge feeling of wanting to look after them, to stop anything dire happening, at the worst case scenario, as sort of a fatal attack. And it's really hard, and I think we often step in and take control over that. And then I've got in mind that adolescent growing up, but it's not an easy choice. So I think that's probably the hard side of the cases.
Yeah, no, that's true.
I have one just that's COVID related, actually, with a young lad who was born prematurely, and pretty chaotic in his lifestyle, a single parent. The last time I'd seen him face to face was in February, and he was smoking cannabis, and his mum was just sitting there nodding, and I was saying, but your lung function's really bad and your asthma's really bad at the moment. And I gave him a bit of a hard time about it, and then I did a telephone review with him, and I was asking how he was, and he was chatting to me. He's always been quiet, and I said, and can I ask about smoking and cannabis? What's happening? Still smoking cannabis? And I gave him a really hard time, and then I said to him, and how's mum? And she had died. And I honestly nearly died. I was so distraught, because I'd taken the stance that he told me he was fine. He didn't give me any indication anything had happened. And it was only because I asked about mum, because mum was so involved in his care, that he then told me. And I thought, now he hasn't got anybody. He's got a brother. And I felt terrible. I felt absolutely, and I still feel terrible. And I'm sharing. I felt awful, but I don't think I would have done anything different, because I was liaising with him.
Mm.
Yeah, that's really tough. And I think that also goes back to Fran's question about looking after ourselves. And I think that's probably a really good thing to finish on, to all those that are actually listening, because actually it's been tough over the last few months with COVID. And I think we all need to remember to look after ourselves and who we are actually getting our own support from, because we're not seeing each other in the same way. We're in this rather strange world. So I recognise that I've actually ran over, poor chairmanship, but if there are any other questions afterwards, obviously if you need to go, then please do. But before you do, I'd just like to say a huge thank you for these two excellent presentations from Sam and Fran today. I've learned a lot, and I hope you've learned a lot to take away into your own practice or to your own homes to look after your own children with asthma. And I'd also like to say a big thank you to Chris, Sonia and Georgie, who've been beavering away in the background, keep making sure that this all functions well. And we will be providing you with the slides and the recordings on the website shortly. And we have also popped in the chat an evaluation, so we'd really appreciate if you could take some time to fill in the evaluation. Oh, okay, somebody's gone. So yes, thank you very much, Sam and Fran. It was great.
Thank you.